Welcome everybody to this week's Miami Global Brain Tumor Symposium for June 10th. I'm just going to start with some introductions here. My name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons here at the University of Miami and Director of Research for Brain Tumors. And I'm joined today by Dr. Morcos, who's one of the co-directors, professor and chairman of the Department of Neurosurgery at University of Miami and director of cerebrovascular and skull-based surgery. Also by Dr. Komatar, who is the director of the Brain Tumor Initiative, as well as director of surgical neuro-oncology and our program director for our residency program. Dr. Benjamin, who's one of our brain tumor skull-based specialists in the neurosurgery department, as well as is going to join us today. For the administration, who really makes everything possible, I have to say thank you to them. They do so much work throughout the week, sending hundreds of emails, working our social media. Christina, Ingrid, and Ignacio have done an outstanding job. And special thanks to Roberto Suazo, who does all of our graphic design, flyers, and everything you see posted. The team together has done an exceptional job, and we couldn't make this possible without them. So many thanks to them. For anybody who has questions about the symposium or about future symposiums, you could always follow us on Twitter at Neurosurgery. Also, all the videos will be recorded and posted on our YouTube channel at University of Miami Neurosurgery. You could search there. It has our symposiums, both the brain tumor and the cerebrovascular skull-based symposium, as well as our grand rounds. For more links for registration, you could always visit our department's website and then click on Symposiums. And then we'll always be giving updates and information on registration on our Twitter and Instagram accounts, which are here. Quick shout out for tomorrow. On Thursdays, we have the Cerebrovascular and Skull-Based Symposium every week that's run by Dr. Morcos. Tomorrow's lecture will be talking about brain AVMs, natural history, as well as surgical treatment. So make sure not to miss that tomorrow at 5 o'clock. And also a teaser for next week on our Brain Tumor Symposium, we'll be welcoming Dr. Stumer from Germany, who will be talking about the present and future uses of 5-ALA, derived porphyrins in brain tumor therapy. I'm sure it'll be an exciting topic, so make sure you tune in next week. A couple of things for housekeeping. We encourage this to be as interactive as possible, so please use the Q&A button at the bottom to type all your questions. We'll try to get to everybody's questions throughout the meeting, as well as at the end. We don't offer CME at this time, but we will get an email confirmation documenting your participation. And make sure you like, follow, and share all of our videos on Instagram, Twitter, and YouTube, so we can continue to grow and share all of this great education that's being provided by our excellent panelists and team. So on to this week. This week we have really an exceptional panelist. Started off by Dr. Kanzioka, who's a world-renowned neurosurgeon from New York. He's a professor of neurosurgery, vice chair of clinical research. He's also professor of radiation oncology and director for the Center of Advanced Radiosurgery at NYU. He's also the associate editor of Journal of Neurosurgery and director of the American Board of Neurological Surgery. We have Dr. Isaac Yang, who's joining us from LA. He's associate professor of neurosurgery, otolaryngology, and radiation oncology from UCLA Medical Center, a specialist in brain tumor and skull-based tumors. He's not only a surgeon, but also a basic scientist with a lab that focuses on brain tumors. And we also have Dr. Christine Din, who's associate professor of otolaryngology, who specializes in otology, neurotology, and skull-based surgery. She's from the University of Miami. She focuses primarily on acoustic neuromas and leads our acoustic neuroma research at the Basic Science Laboratory, as well as in clinical work. So a really comprehensive list of multidisciplinary, as should be, for discussing today's topic. Special thanks to our keynote speaker tonight, which was Dr. Link. He's a consultant in the Department of Neurosurgery and ENT at the Mayo Clinic in Minnesota. Also the director of skull-based dissection laboratory and the director of the skull-based fellowship there at the Mayo Clinic. He's a past North American skull-based president and the co-editor in chief of the Journal of Neurological Surgery, Part B skull-base. Dr. Link is talking about acoustic neuromas today, and he's really world-renowned in his research, both clinically and as well as we'll talk about quality of life today in this research, as well as many other skull-base types. His particular interests in research are focused on outcomes research, specifically quality of life and functional outcomes after the treatment of skull-base tumors. He leads multiple studies on prospectively looking at quality of life in acoustic neuroma patients, both followed conservatively with radiosurgery and with resection, and multiple of these are in conjunction with the association, the Acoustic Neuroma Association. So we're very, very lucky to have him talk to us today. You can see here he was a great debater at the last Skull-Base Society when it was Extra Mayo versus Miami Vice. A picture of that debate there, which was really well performed by both teams. And so I'm sure tonight is going to be equally as exciting. Dr. Link, thank you so much for joining us tonight and sharing your approaches to acoustic neuroma.
I am sharing my screen here. And great. Thank you so much, Michael. Can everybody see my slides okay?
Yeah, that looks good, and we could hear you well.
Okay, great. Well, good afternoon, everyone. I'm delighted and honored, I'll say, to be able to speak to you about a topic I've dedicated my clinical research efforts towards and about which I am quite passionate, and that is what is the best treatment for vestibular schwannoma, and specifically, what are our patients telling us about our treatment outcomes? I don't have anything to disclose. I'm sure I have some biases about how vestibular schwannoma should be managed, but I hope I've been mostly open-minded about that. I bet most everyone listening has been confronted with a scan like this, a small vestibular schwannoma, and a colleague or a mentor or a trainee or your spouse's third cousin's hairdresser has asked you, what do you recommend? Seems like a pretty straightforward question a neurosurgeon should be able to answer. But of course, actually, as you all know, it's a hell of a lot more nuanced than that. You know, your response may be a lot different if I say the patient is 35 years old versus 75 years old, if they have significant health issues. The one thing that is at most risk, no matter what option is chosen, is the hearing in the ipsilateral ear. It's very important not only to know what the audiogram shows, but how the patient perceives the usefulness of that ear and how the hearing is in the contralateral ear. Perhaps presenting chief complaint like disequilibrium or trigeminal neuralgia would sway you one way or the other. Often patients come for second or third or seventh opinions, and they may have been told certain things that you either agree with or strongly disagree with, and you have to try and persuade a layperson based on your own interpretation of the literature. And finally, I suspect we've all altered our practice patterns over the last few months because of the coronavirus. One of the big issues is the tumor growing? Of course, that's often the key question that helps drive our decision making. And in this case, indeed, the tumor grew over about 17 months of imaging. And patients will often ask, well, what do other people in my situation do? And of course, we rely on our own experience with prior patients. And so I want to tell you just three quick vignettes. So these are three patients that I think are very interesting because they have similar tumors and they have really identical clinical outcomes. So the first patient is a 67-year-old woman that I followed for 8 years. And if anything, her tumor looks like it may have gotten a little bit smaller in follow-up. Over that 8 years, she's lost about 10% word recognition and 5 decibels of pure tone hearing, otherwise normal facial nerve function. The second patient is a 62-year-old man I treated with Gamma Knife radiosurgery 5 years ago. And you can see he's got a very good, robust radiographic response. And his audiogram 5 years after treatment looks basically identical to the first patient. He's lost about 10% word recognition score, but only 5 decibels of pure tone hearing, still class A, very useful hearing. And the third patient is a 33-year-old man who actually was born and raised in South Sudan and then migrated to South Dakota. And he showed up with this tumor, which we removed. He still has Class A hearing, again, an audiogram almost identical to the other two patients, and normal facial nerve function. So I would ask you, which patient is happiest? Which patient do you think enjoys the best quality of life? Which patient would we want all our patients to emulate? And unfortunately, the answer is none of these patients are happy. In fact, all three of these patients are quite miserable. The first patient had her tumor diagnosed because of ongoing disequilibrium, and she still is very dizzy. We send her to vestibular rehab. She says it doesn't help, and she's becoming socially isolated because she's afraid to leave her house because she's afraid she's going to fall. The second patient, despite having really quite good hearing, complains of horrible disabling tinnitus and oral fullness, and he's even contemplated a suicide. And the third patient had that tumor discovered because he had disabling headaches. And of course, guess what? He still has terrible headaches. And when I see him in follow-up, the only thing he wants to talk about is having me fill out his disability paperwork so he doesn't have to go back to work. So there's hardly a more controversial topic, right, than what is the best management for a vestibular schwannoma? And it's not a new controversy. I mean, this topic drove a wedge between Harvey Cushing and Walter Dandy. I like this picture because I think it suggests neurosurgeons are thoughtful, distinguished people versus politicians, which I don't think have that reputation in this day and age. So what do we know so far? Well, several years ago, I ran into Morten Lund Johansen, who's a neurosurgeon in Bergen, Norway, and we were talking about this disconnect between what we think is a good outcome and what patients perceive as they're not happy. And what we decided to do was kind of join forces, and we surveyed all patients seen at each of our institutions with tumors less than 3 centimeters. So technically they had all three options, observation, radiation, or microsurgery available to them. And we enrolled 247 patients who had undergone radiosurgery, 148 that had undergone observation, 144 that had had microsurgery, and we also surveyed 103 non-tumor controls in the general US population. And we basically just sent them a questionnaire and asked them to fill it out. We gave the participants in the US $30 for doing that. People in Norway did it for free. And we got almost 80% response rate, which is really quite remarkable. Our survey people say if you get near 50%, that's quite something. And this is what we asked them to fill out. So 3 general quality of life outcome measures. The SF-36, which has been used in a large number of disease states. The PROMIS-10, which is also a general quality of life measure. Both of those scales have a physical and a mental outcome measure. The Glasgow Benefit Inventory, which basically says, did somebody benefit or were they harmed by an intervention? And then the Panacoustic Neuroma Quality of Life Assessment, or the PANQUAL, which is the only disease-specific quality of life outcome measure. And we also ask patients to fill out a variety of symptom-specific inventories to look at specific symptoms. So dizziness, facial function, hearing, tinnitus, headache, and then anxiety and depression. And it turns out our survey had 293 questions. And 642 people participated, which gave us more than 188,000 data points. This is just the PANQUAL. If you've never seen it, it has 26 items, and it's relatively straightforward. Some of the questions or some of the statements are worded very negatively, such as I have discomfort, itching, or excessive tearing in one of my eyes. And some of the statements are quite positively worded, like my health is excellent. Of note, there's only one question that deals with pain, and there's only one question that refers to tinnitus. And you'll be happy to know I'm not going to try and go over 188,000 data points, but I just want to show you the results from the PANQUAL part of the survey. So the blue bars represent the non-tumor controls. The yellow bars are all the vestibular schwannoma patients lumped together. The red bars are the radiosurgery patients. The light green are the observation patients, and the dark green are the microsurgery patients. And I just want to point out a couple things. Number one, you can see for almost all the subdomains that we're interested in with vestibular schwannoma, not having a vestibular schwannoma is much better than having a vestibular schwannoma. So the non-tumor controls look a lot better. There were some differences between treatment groups. For facial function, balance, pain, and the total score, microsurgery statistically scored worse. There was rarely any difference between observation or radiosurgery. The other thing that's interesting is I tend to think of vestibular schwannoma patients as being rather anxious, but when you look at the anxiety subscore, there was really no difference, including in the non-tumor controls, which makes me think there's something fishy about our non-tumor controls. Maybe these are people who are anxious about their health and were willing to fill out 293 questions, even though they don't have the disorder we're interested in. And if you want to really look at the details of that, this is the reference. We published it in Journal of Neurosurgery in 2015. And from our standpoint, the long and short of this is that at almost 8 years following the diagnosis or treatment of a vestibular schwannoma, the differences in quality of life measures between groups were small. It's the diagnosis of a vestibular schwannoma rather than the treatment used that most impacted the quality of life. And we also found that general quality of life instruments like the SF-36 or the PROMIS-10 couldn't even figure out who had a tumor and who didn't have a tumor. So the disease-specific PanQual is really the best we have right now. And I'll just add that in the PanQual, a higher score is better. So the scores range from 0 to 100, and 100 would be perfect, and 0 would be the worst quality of life possible. So is that the answer? Do we have the answer in terms of what's the best treatment? Can we use this data? And of course, we have to say, probably that's not the answer. I have to emphasize, this was just a long-term snapshot. This was just asking patients almost 8 years after whatever treatment they had or their diagnosis. There was no crossover between groups. It just said, how are they doing at that long term? And of course, the other issues, they were our patients. So maybe there was some type of bias in that either they really thought that link is a jerk and I'm going to stick it to them and tell them how bad I'm doing, or they say, we really like our doctors and we don't want to upset them, so we're going to say we're doing quite well when maybe we're not. 20% of patients didn't respond. Maybe the 20% that were doing really bad, maybe the 20% that were doing great, although we think not. When we looked at tumor sizes and patient age and so on and so forth, hearing outcomes, facial nerve outcomes, the ones who didn't respond and fill out the survey looked very similar to the ones who did. I think one of the key questions is, are we asking the right questions? Are we getting to the bottom of what we really want to know? And are p-values the correct arbitrator? So it brings up this issue, for example, that if you look at what I just told you, you would think that we should say to patients about to undergo microsurgery that they have a significantly increased risk of a reduced quality of life almost 8 years after treatment. Because the total PanQual score in the observation group was 72, in the radiosurgery group was 70, and in the microsurgery group it was 65. And the difference between 65 and 70 or 72, when you have the large number of patients we had, more than 500 patients, turns out to be highly statistically significant. However, there's this concept of the minimum clinically important difference. So in a 100-point scale, can a patient really tell if they're a 65 or a 70? And so it turns out Kathleen Yost, Dr. Yost here in our survey research department, is kind of an expert. And she helped us look at both those patients I just told you about and a larger group of patients to come up with what is the minimum clinically important difference for the PanQual for each of the subdomains. And this is what it showed. So the blue numbers and bars are actually based on more than 1,200 patients when we partnered with the Acoustic Neuroma Association. So we pared down our 293 questionnaire to just 64 questions, including the 26 from the PanQual, and we offered any patient who signs on to the ANA website can fill out our questionnaire, and we'll include them in our analysis, no matter how they were treated or when they were treated. They just had to know the size of their tumor and what treatment they had. And for instance, it showed that on the hearing subscale, you would expect a patient has to change at least 13 points on a 100-point scale for them to actually notice a difference. The total PanQual score, it was 12.5. And then we were keenly also interested in, of these things, of hearing loss, tinnitus, facial weakness, imbalance, headache. What's really driving this decrease in quality of life between patients who have a vestibular schwannoma and the normal controls in the US population that don't? And so you can examine the weighted contribution of the baseline patient and tumor characteristics like age and sex and tumor size and the treatment modality we did, and then their postoperative symptoms. Are you dizzy? Do you have headache? Is your face weak? Is your eye dry? And so on. And then using multivariable regression analysis, you can find associations between those candidate predictors and the total PanQual score. And it showed that actually sex, tumor size, and treatment modality, whether they were radiated, operated, or just observed, it didn't influence their long-term quality of life. But there was a real hierarchy in symptoms that affect quality of life. Dizziness and headache were the two really big ones, and they were almost equally. Dizziness edged out headache a little bit. Tinnitus came in number 3. Facial function was number 4. And the thing we spend a lot of time in clinic talking to patients about what's going to happen with their hearing was a distant number 5. So kind of as I mentioned, we thought we need to cast a larger net here. We partnered with this group in Norway, thinking we're going to do an international study looking at quality of life. And then we realized most people in Minnesota are of Norwegian descent. So probably we ended up surveying a whole bunch of cousins in our study. So we thought we should look broader at the United States. So we partnered with the ANA. And we classified patients by treatment at the most recent survey into either having microsurgery, radiation, observation, or they were recently diagnosed, meaning they filled out their survey within 6 months of the diagnosis. And we used our previous non-tumor controls to compare to. And we excluded any patients that had multimodality treatment, gamma knife, then surgery, or subtotal resection and gamma knife. Those were excluded, and we excluded NF2 patients. And we recently looked, none of this is published data now, but we recently looked at more than 1,000 patients, 1,362, about 60% from the ANA, so from all over the United States, and 40% were our patients here at the Mayo Clinic in Rochester. 685 had microsurgery, 271 had had radiation, 290 were under observation, and 115 were just recently diagnosed. And sure enough, just like at our institution, there are biases as to how patients are treated. So I don't know if you can see the p-values on the far right, but for instance, patients who underwent microsurgery were younger than those who underwent radiosurgery or observation. There was a stronger percentage of female patients as an effect of, there are more female patients who join the ANA. About 60% of tumors in the observation group were less than 1 centimeter, but only 27% in the radiosurgery group and only 14% in the microsurgery group were less than 1 centimeter. So not surprising, larger tumors tended to be operated on. And for most of the groups, the duration of follow-up was somewhere between 0 to 5 years, but we had some very long-term follow-up as well. And this is basically what it showed. And I'm sorry about all these numbers and how horribly boring this slide is. But basically it shows what the outcome of the PanQual was for each of the subdomains in the microsurgery, radiosurgery, observation, or recently diagnosed groups. And we did statistical analysis, and if the whole analysis showed a significance, then we did pairwise comparisons, as well as we looked at, did the difference fall within the calculated minimum clinically important difference, meaning did we think it was clinically significant, not just statistically significant. And sure enough, just like I showed you with the Mayo and Norway patients, for the ANA and the Mayo patients, there were some differences. Facial nerve function was worse in the microsurgery group compared to both observation and radiosurgery. Hearing loss was worse in the microsurgery group, and the microsurgery patients had more pain. And it's reflected in these lower scores on the PanQual in the subdomains for those characteristics. And this is just what it looks like in graphic form with, once again, the differences aren't very great, but there are some where it becomes statistically significant. The interesting thing, both in our previous study and in this more updated series of more than 1,300 patients, is the hearing outcomes are drastically different. So only about 14% of patients in the surgery group have useful hearing. It's about 40% in the radiosurgery group and more than 60% in the observation group. But yet the hearing scores are very similar, ranging from about 45 to 55, which I think indicates if you lose a little hearing, it affects people a lot more than we think. And you can see again, the total scores look very similar to our smaller group and are very closely clustered together and not statistically significantly different. This is just the scattergram of each individual patient. This is the total PanQual score, microsurgery, radiosurgery, observation, the recently diagnosed, and these are the non-tumor controls. So again, these are various snapshots at various times, and we tried to see, does duration of follow-up matter? Meaning, maybe the patients way down the road, more than 11 years after treatment, all look the same, but in the early part, within a couple years of treatment, we could find some bigger differences. So there's a statistical way to look at this using interaction terms, and we compared the different groups and the different follow-up times. And somewhat surprisingly, there were no interaction term that was statistically significant, indicating that the effects of treatment on the PanQual scores were appropriate to apply regardless of the duration of follow-up. But weren't quite certain about that. And so we wondered about, does the quality of life really change over time? And so we started to do prospective longitudinal study where when we first see the patients now in Rochester, we ask them to fill out the questionnaire. So they haven't yet made their decision about what they're going to do, and then they make the decision, and then we do whatever they and we have decided, and then we continue to follow them. So now we have 244 patients where we have baseline data before they chose what they were going to do, and then ongoing data. We have 78 in the observation group, 118 patients who've undergone microsurgery, and 48 who have undergone radiosurgery. And the mean duration now between the baseline and the most recent survey was a little over 2 years. And the mean number of surveys was 2. And there's no difference in the observation microsurgery or radiosurgery group in either the time since diagnosis or the number of surveys they filled out. And once again, this is what that looks like. So again, surgery patients turn out to be younger. Surgery patients tended to have larger tumors, and we can control for that when we look at the results using regression analysis. Now, when you look at the hearing results, there was really no difference at baseline. So about 50 to 70% of patients had what we would consider to be useful hearing prior to treatment. But at most recent follow-up, only 19% of the surgery patients still had useful hearing, whereas 61% of the observation group did, and 27% of the radiosurgery group did. Similar with facial nerve function, basically all the patients started out with normal facial nerve function, and there was a statistically higher chance of having not normal Houser-Brackmann grade 1 or 2 facial nerve function in follow-up in the microsurgery group, which you can see here. 6% were Houser-Brackmann grade 3, and 2 patients had no facial nerve function when we got done with them. And this is kind of, I think, the main point that I want to talk about, is that this is before we did anything to the patients. And I had really assumed that all the patients were the same, meaning they all started from the same place, but they actually don't. So the patients in the microsurgery group had an anxiety score of 65, which is more than 10 points worse than the observation group. They started out with a lot more pain based on their quality of life score, 60 versus 79 or 72 in the radiosurgery group, and their total PANQOL score was only 65 versus 75 in the observation group or 70 in the radiosurgery group. So that was kind of an eye-opener. And then when you look at their most recent scores, you don't see that anything has budged. Not much has changed despite going through 2 years of observation, having had a major intracranial operation, having your tumor removed, or having undergone gamma knife radiosurgery. And when we look at this, now looking at the delta or the change in PANQOL scores, and again, I'm sorry about all these numbers, you can see for the observation group, after 2 years, there's really no significant change. The numbers fluctuate between 0 and 5 points one way or the other, but it's not very significant. The only significant is the anxiety subscale in the microsurgery group got better. It got 10 points better, but once again, they started out with a much worse anxiety score. A recent paper also just came out in otology, neurotology by the group at Penn who developed the PANQOL. And they also basically did the same thing. They looked at, is there a longitudinal change in the quality of life scores over time? And basically this is their plot that shows there's really not. They tend to stay the same. Patients stay the way they are when they show up in your office. So, what can we say about all this? Well, certainly a disease-specific quality of life analysis reveals very little difference in the outcomes between the different treatment arms. Longitudinal analysis reveals the anxiety subdomain improved some. In our analysis after microsurgery, the group at Penn actually showed it got worse. So I don't quite know what to make of that just yet. So I don't think we've cracked the code on figuring out which patients will benefit the most from a particular treatment strategy. And maybe the corollary is you can't go wrong. Maybe whatever they decide is going to be appropriate. And where do we go from here? Well, these are the things that I'm thinking about. Is certainly at some point we have to start thinking about cost analysis, right? So we're kind of keen to look into how that might fit into all of this, both cost to the institution and cost to the patient. We're really keen to answer the question, can we develop a better quality of life assessment tool? I'm not convinced we're asking all the right questions. I think one really intriguing question is, could we ever randomize vestibular schwannoma patients? Meaning, I'm sure if I asked all of you, do you like the house you live in? Are you happy with your spouse? Do you like the car that you bought? We're so invested in the big decisions in our lives that I think most patients want to say they made the right choice. Nobody wants to admit, I did something I wish I wouldn't have done. And we have actually asked that question to patients. We have asked them, Are you happy with your decision? Would you recommend what you decided to a family member? And the vast majority of people answer that question, yes, I am. But if we took the power of the choice out of the patient's hands, what would their quality of life outcomes look like then? So I want to stop there to give the other panelists a chance to speak, and I'd be happy to try and answer any questions. I want to acknowledge the ANA, which has been great to partner with. They've given us access to a lot of patients in a very anonymous way that we can generate a lot of this data from. I want to thank our colleagues in Norway that have been great partners, and our team here at Mayo, Matt Carlson, Colin Driscoll, Brian Neff in ENT, Christine Losi does a lot of the statistics for us. So once again, I'll stop there, and thanks very much, Michael and Jacques and the whole team at Miami for putting this on.
Great talk, Dr. Lake. Thank you so much for
I'm
that.
Stop sharing my screen there. Okay.
Yeah. We'll just get to a couple of the questions from the audience before we start with the panelists. Shanann asked, Dr. Link, thank you for the presentation. Since hearing loss is correlated with cognitive decline, did you consider cognitive decline as a possible covariate in the statistical analysis?
Yeah, it's a very interesting point. We don't have any measures of cognitive function. One interesting thing that I don't think it gets to the point of the question as well as I would like is we recently looked at audiogram data. So we usually think, right, somebody who has a pure tone average of 50 decibels or less and a word recognition score of 50% or better has useful hearing. But in fact, when we ask patients, do you struggle with conversation? Can you use a telephone? Those kinds of day-to-day questions about hearing. Are you having trouble with social interactions? If they scored less than 70% on a word recognition score, they all look the same. They all report the same thing. They have trouble in conversations. They have trouble in social interactions. They have trouble hearing in noise, and so on. So probably we're giving ourselves too much credit. But I think the question is a good one. But I don't have any data or way to get to the bottom of that.
Sure. And then 2 questions here talk about tumor size and Coues classification. How is that influential in decision making and quality of life decisions?
So most of our initial data, we looked at what we would consider to be kind of small and medium-sized tumors, less than 3 centimeters, and we could not find a correlation between any of the parameters and tumor size. With pairing with the Acoustic Neuroma Association, then we get a large variety of tumor sizes. And there's no question it correlates to hearing outcomes and facial nerve outcomes, but not necessarily quality of life outcomes. So the total PanQual scores don't vary all that much based on tumor size.
Okay, let me see a couple of these other ones. Any questions from the panelists before we go on to the next part? Okay, great. So let's just move on to Dr. Kanzioka here. There's a couple other questions, but I just want to keep things moving along. Share the screen.
Thanks, Mike. Can you hear me okay?
Yes.
That's great. Well, I really appreciated Michael's talk and the tremendous work they've done at Mayo together with the groups in Bergen with the Acoustic Neuroma Association has really led the field at understanding. There's so much information there, it's almost difficult to distill. And if I was to be at all critical about it, I would just say perhaps we've spent a little bit too much time thinking about anxiety and not some of the other elements of function, including dizziness, balance, tinnitus. And I'd just like to talk about that today. So next, please, Mike. You go to the next slide. So we studied this from my time at the University of Pittsburgh a number of years ago. And in fact, when we compared quality of life of our radiosurgery patients to patients who do not have a vestibular schwannoma, the overall data was fairly similar to population norms across different age groups. And it kind of tells us that overall, I think we're doing a fairly good job with these patients. And I think Michael showed some of the, the nuance there. But when I talk to patients, I kind of list for them the 4 things that are most important in order. It kind of agrees with what Michael just said. Number 1 is stopping the tumor. And that maybe leads into the anxiety issue. So, a happy patient is a patient whose tumor has been controlled one way or the other. They don't have any facial weakness. Their balance is good. And number 4 is hearing loss. And as he alluded to, these patients often come with, we spend a lot of time on hearing, but it's probably the most, it's the 4th most important outcome. And we got this information from the Acoustic Neuroma Association and from the patients. Next, Mike. So they really have to understand, that when they're choosing quality of life, how fast these tumors grow. And I show them our data as well as the Mayo data, which I think is the best current data on growth rates, because the patients will often ask, well, if I'm going to preserve my function, they hope it might not grow or grow slowly. And you really need volumetrics to understand this. And Michael showed a case where the tumor was a little smaller. In our 200 patient series, that only happened, in 2 patients. And if you go to the next slide, you'll see that over an approximate average of 2 years, about 1/3 of the patients, it didn't change much. 1/3 it grew at a fairly regular rate, that's more than 20% by volume per year. And 1/3 it grew more quickly, which was more than 100% by volume per year. And you can see that within a relatively short period of time, about 70% of the patients eventually came to some form of treatment. And so from a quality of life perspective, they need to understand the biology of this tumor and what they're getting if they choose observation. Next. Well, here's a patient who chooses observation and has a small intracanalicular tumor at 8 millimeters. And, they're often told by either the otologist or maybe whoever saw them initially, and there's a lot on the web on this topic, that these tumors, quote, hardly ever grow, don't grow, may never grow, you may never need to do anything. And yet 6 months later, here's a tumor at 12 millimeters, and the patient had a 92% speech discrimination score that was lost within 6 months. Could that have been prevented if the patient had been managed earlier? We just don't know that. Next. Here's another one with another small tumor, 5 millimeters in 2012. A year later, it's at 10 millimeters. And you might say, well, that's 5 millimeters over the course of a year, not the usual 1 millimeter per year we often talk about for intracanalicular tumors. But from a volume perspective, that's probably a 300% volume change. And the hearing has gone down. It probably reflects that stretch of the nerve in different directions. Continues to be watched at 17 millimeters. And the radiosurgery is done, and you can see the 6-month change. And then, unless you're measuring these volumetrically, we can't really understand why did the hearing go down if the change wasn't much. And the patients will hope that they will preserve their function. And we have some work that will be published soon showing that the rate of growth actually did not correlate with what happened to hearing. And that's what the Mayo data shows as well. Next. So here's perhaps their ideal result. If we were to look at the perfect patient, the patient has a small tumor. It's not in the distal fundus. It's away from the cochlea. You can see it has radiosurgery. There's a classic 6-month scan with loss of contrast. At 18 months, it's regressed and is barely visible. You can see it on KISS. The cochlea remains bright on T2, and this is what I call a healthy cochlea. A dark cochlea, typically either related to protein content in the fluid, is usually one associated with hearing loss and a preserved audiogram. So this is, how do we get this patient more often? Because this is really the optimal quality of life outcome. Now, of course, we don't know if that hearing preservation will be durable past 5 years, but at least in the early phase, this is the happiest person I can take care of. Next. So here's a 70-year-old, and you can see, and this tumor had enlarged before radiosurgery. And there's different things that people do, including saying that younger patients do better under the age of 60. Well, here's a 70-year-old, or lower cochlear dose does better. And here's one that's a mean dose, and yet hearing has been preserved. Next. And I just want to show you that, we're getting to the point where, in my practice, I often wonder, when will this happen? When we would say to a patient, listen, you have a small tumor, you have excellent hearing. Observation leads to growth and hearing loss in the majority of patients over the next few years based upon the volumetric data. And we're now showing that hearing can go down even without much growth. And therefore, you should be treated now when your function is best, as opposed to observed. Well, I don't think we're ready for that kind of conclusion yet at a quality of life level. The patients are not ready for it. That kind of concept will likely happen when the multitude of reports from leading centers show this. Or we move to something that will be very different, because we're now collecting a lot of data in prospective registries at leading centers. And I think radiomics and machine learning are going to evaluate these disease-based features and provide a recommendation to the patient. And the doctor's opinion may have a lesser role, because as Michael said, I love his first slide with this kind of gobbledygook image of information going off to the patient. And it may be that computers articulate this better. Next. And just to finish, I want to show you, this is data from about 1.5 years ago, but it's my own hearing preservation data and it's not another center. And I think when you're looking at multi-center trials, we really have to look at your own data in this disease. But it shows that people who come in with excellent hearing, that's a speech score 90 to 100, that in the vast majority, we're preserving that in these people. But if you go to the next slide, and this is patients whose hearing has dropped before I've taken care of them. So typically they've been watched, and their score is now in the 50 to 90 range, and you can see it's like raining. The hearing scores are going down. We're not preserving these patients at quite the level they are when they come in. So if hearing is one of the main reasons to try to preserve their quality of life for the long term, particularly if they ever lose hearing in the other ear, we have to intervene earlier. And so I would just put that out there. But to conclude, one of the disconnects in quality of life is that we don't study dizziness like we study hearing. You know, patients do not get serial VNG tests, which are often nauseating and uncomfortable. And we don't have a great way to quantify tinnitus. And I think these other elements of quality of life require a whole new avenue of research that largely we've kind of ignored because we haven't had a good way to study them. And I'll finish there. Thanks, Michael.
Yeah, I think that brings up a great question for Dr. Link, and that's the patients that were in the quality of life study, you know, in the observational study, and their quality of life decreased over time. Once that quality is decreased, it's never you can never recapture that quality, right? And I think that's echoed by Dr. Kanzioka.
I'm sorry, you cut out just a little bit. Were you speaking specifically about the hearing?
I mean, it could be related to all of the characteristics.
Yeah, right. So, if you do something or something happens to the patient that their quality of life is reduced, it's nearly impossible to get it back. The question, of course, or what we talk to our patients about is what we're going to do to you worse than what is natural history going to do to you, right? We don't want to push somebody into a worse quality of life by irradiating them or operating on them. What I say to patients, frankly, is most patients who show up with a tumor growing from their 8th cranial nerve will end up losing useful hearing in that ear. It's the minority of lucky patients that get to keep the hearing, and it becomes of kind of a when and how do they lose that hearing? Is it slowly over the next decade? As Doug said, even if the tumor isn't growing, that often happens. Is it 2.5 years after I treat them with radiosurgery, or is it, as certainly happens, when they wake up from their operation that I did?
No, great points. Great points. One question here from the question and answer is there any difference in these quality of life assessments or management of the patients when they have NF2?
Yeah, there's definitely a big difference. It's certainly another disease process, because now you're looking at somebody who's going to likely end up completely deaf, Often their vision is threatened based on meningiomas around their optic apparatus, plus other meningioma burdens. You know, one of the reasons a lot of NF2 patients die is they become either paraplegic or quadriplegic due to tumors in the spinal cord. So it is a completely different disease state, certainly, and many different additional impact factors on their quality of life.
And one question for Dr. Kanzioka was, for those patients that you did have small tumors where you preserved hearing, what was the dosage, the cochlea that you found to be the optimal dose to get that great data that you showed?
You're muted, Doug. Doug, you're muted.
Yeah, and, you know, most centers have, over the last decade, have tried to keep an average cochlear dose below about 4.2 gray. I actually, in the one of the first publications came from our group on this. I don't actually believe that it's critical, and because the data we've collected has shown that between 2.5 and 5 gray, it probably doesn't matter. And in fact, I'm a big fan that we're not learning fast enough because we're not measuring the right things. You know, we can measure how big a tumor is, we can measure how old somebody is, we can measure a dose like a cochlear dose, but we can't measure how long the tumor's been there. We can't measure the microcirculation to the cochlear nerve. We can't measure the baseline health of the cochlear hair cells. These are probably more important factors than the dose. Nevertheless, all of us try to keep the dose as low as possible, and we'll have to see if we're doing better at 10 years than some of the older data, because as Michael said, you know, the hearing preservation data can look good at 2, 3, 4 years out, but the issue is, can it be maintained in the 8 to 10 year range? And so we'll have to see.
Okay, great. Dr. Yang, do you want to show your cases?
Great. I'm going to share my screen now. Can you see my screens?
Yeah, that looks good, Isaac. Thanks.
Great. So I want to thank Dr. Ivan, Dr. Morcos, Dr. Komotar, University of Miami for having me. This is a wonderful idea, especially during this pandemic period. And, you know, being on this panel and following Dr. Link and Dr. Kanzioka is exceedingly humbling. It's like following LeBron James and Tom Brady. You guys can pick which one you are, but I mean, it's very it's nerve-wracking to follow them. And so I'm just going to present some of my cases that talk about this disease. And just like Dr. Link said, you know, the thing that he's trying to measure is happiness, and that's really hard to measure. Anxiety is hard to measure, and like Dr. Kanzioka said, it's relatively easy to measure tumor growth. Or if you want to you know, measure, you know, hearing, you could do, you know, audiogram. There are things that you can measure, but happiness is really hard to measure. And that case where he goes, which one of these patients are happy, that's really hard to do. And so, you know, this is my practice. I have a 50-year-old female, and her facial nerve's intact, but she has a little bit of jaw, she has some numbness in her jaw, and this is the size of her tumor. So she's 50 years old, and she has this tumor that's a little over 2 centimeters. And I would think that most times I've seen tumors much larger than this that do not present with, you know, some facial tingling or numbness. And we elected to do surgery, and we got gross total resection, but post-operatively I have a video, and she's Housh-Brackman 4. She's unable to close her eyes immediately post-op. This is and then in my clinic, weeks later, she's able to open and close her eyes. I'll skip the video and you'll just take my word for Housh-Brackman 1. And that was what we did. We went so hard, and we did a gross total resection. And then one of the things that you have to keep out for is on the review here, they said I had a residual tumor. And I said, but I had a gross total resection. This is the actual MRI report, and I blocked out the information, but you can see that the initial report said that there was a 12/15 residual. And then the addendum, once I called them back and said it was actually fat that I packed in there, you can see the addendum at the top says it was fat packed in there and it wasn't residual tumor. But just talking to the patient who's Housh-Brackman 4 at that time, when they come in with this report, it's extremely distressing, and it changes their quality of life. On the flip side, you know, radiation also has its fair share of things that can impact quality of life. This is a patient of mine who, when she was 60 years old, she received 16 gray of radiosurgery in 1990. A generation ago, when they were still trying to hone down the exact dose for the acoustic neuroma. And in 2015, this was the size of the tumor, and it was on the left side. But that tumor, it grew. It grew after radiation. And you can see here, the tumor grew, and it looks like it just grew like a little secondary nipple. And so when I saw that, I told my resident, I'm going to biopsy here, and it's going to come back meningioma, and I'm going to resect here, and that's going to come acoustic, and I'm going to write it up. I was like, we should start writing this up before the pathology came back. But actually, it all came back as just acoustic. And I got a healthy subtotal resection here, a lot of residual, and this patient still came back as Hauss-Brackmann 6. I'm just telling you my experience is that I didn't even see the facial nerve here. I left so much residual, I didn't have to see it. I wanted to guarantee that she would be Hauss-Brackmann 1, and she was still Hauss-Brackmann 6 after the surgery. The story gets worse, though. You would think that this is how bad the story gets. A year later, this is how fast the tumor came back. And in 2016, the pathology was an acoustic neuroma. After this surgery, the tumor came back as a malignant peripheral nerve sheath tumor. And so this was a generation after the radiosurgery done in 1990. And I think that's something to see. And I just postulate that there as discussion points. This is the last patient of mine that I want to present out there. This is a 60-year-old man, and he presents with hearing loss. And this is the audiogram. And just like Dr. Kanzioka said, you can measure hearing. And I just want to point out the speech discrimination score is 48. So, his hearing is technically non-serviceable. And so we did the surgery. This is the tumor. There was a little bit of residual, but the vast majority of the tumor has been removed. But the point I want to point out in this patient is, and this is his actual audiogram, his audiogram went to 66. His speech discrimination score now went from what we would consider non-serviceable, just barely, to serviceable hearing. And this is with surgery. And I love that slide that Dr. Link had about Trump and Biden and Dandy and Cushing, and about how this is such a controversial, and it stirs up such emotions, but this is a case where surgery improved hearing. And there are papers that discuss, hearing preservation after surgery. And so there are different areas to explore. And one area that my mentor, Andrew Parsa, helped develop was this concept of hybrid surgery. Is there a midpoint between maximal resection and lowering the radiation dose? And I don't know, but it's an area that's being explored. When we tried to study this, when we tried to study some of the computers and the AI that Dr. Kanzioka was talking about, how to computerize the assessment of what's the perfect resection, you can see that there's 4 surgeons here. And what we found is that we surgeons, we don't agree on anything. It's really hard to get surgeons to agree on what the right radiation dose is or what the right surgery is. And that paper is here, you can publish it. And then the last 2 points is that something that we're working on here at UCLA is we're trying to do facial nerve tractography. You can see here's the tumor, and we're trying to do the tractography. And I was inspired when I went to go see Majid Sami do surgeries in Hanover, and they were doing facial tractography. And I was talking to Fred Barker about these images. He goes, God, Isaac, it makes great images. And I said, it does. It makes absolutely 0 difference to the clinical outcome. It makes great pictures that you can show, but it hasn't made any difference to the outcomes. The patients are still coming out with the same Hauss-Brackmann scoring, and that there's a whole host. It's really a Pandora's box of stuff that we still need to explore. These last few slides are not slides of mine. These are slides of mine, but this is not my research. This is just continuing to learn about this. And this was presented by Dr. Regi at the last ISRS last year. Was he presented this paper was the waiting and seeing towards Gamma Knife and whether or not early radiosurgery would preserve hearing. And Dr. Kanzioka slightly inferred that it's not well established yet. But when I look at this kind of data, and this is out of the Pittsburgh group, this is a different group looking at the exact same thing, groups that do good science, groups that are pushing the cutting edge. And when I see, and I have full disclosure, nothing to do with either one of these great papers or the science, but when I look at this, I go, you know, there's a whole future field that's going to be coming down. Whereas, is that early radiosurgery good for hearing preservation? I don't know. I've had a lot of people help me with this. There's a whole team at UCLA, and then the team that's helping me during my pandemic and putting up with me. But yeah, I think there's a lot of questions, and it's really humbling. Thank you so much for letting me speak.
Thanks so much, Isaac. Yeah, I mean, I think the understanding, like you said, and Dr. Kanzioka, of why are these people losing hearing and all the aspects that go into hearing loss are not really well understood. And until we understand why that's happening, it's very hard for us to kind of say what treatment would be better, perhaps, in those patients. But treating early is definitely, it looks like the data is being more supportive in that aspect. Okay, Dr. Din?
Okay, perfect. Let me go ahead and share my screen. Can you guys see my presentation?
Yes, that looks good.
I'd first like to thank Dr. Ivan, Dr. Marcos, Dr. Komatar, and Dr. Benjamin for allowing me to speak about vestibular schwannomas. They've asked me to present 2 cases and query the panelists to see what they would do. I am a neurotologist at the University of Miami. I'm also a surgeon scientist. And I will be presenting 2 cases of persistent dizziness after hearing preservation vestibular schwannoma surgery. Let's see. Okay. So my first patient is a 40-year-old male who presents with left progressive hearing loss and dizziness and imbalance for several months. He's very active, he loves to run, he bikes frequently, but the dizziness is interfering with his ability to do these activities and really limiting his quality of life. He has no real significant past medical history, and his physical exam is relatively unremarkable except for his vestibular exam. He had no spontaneous or gaze nystagmus, but when we do a head shake test, I noticed that he had a right beating nystagmus, and that is something that we see very frequently with patients with vestibular hypofunction on one side. Patients that have a vestibular schwannoma on one side, when you shake their head, their eyes generally beat to the opposite side toward the stronger ear. What was a little bit different about this patient is he also had some perverted nystagmus, which is when you get some vertical aspects to your nystagmus and horizontal head shake test. And that kind of clued me into, well, is this patient gonna really do well after the surgery? What is going on with the dizziness? It's just a little bit more complicated than the usual vestibular schwannoma. We did a hearing test, and he had a mild sensorineural hearing loss. He had 100% word recognition score. You could probably grade it like borderline grade A hearing, but his main concern, as I said before, was dizziness. We ordered an MRI, and on the MRI, he had an enhancing lesion that was centered at the cerebellopontine angle. There was a little bit of an extension into the internal auditory canal, a little bit of dilation, and on the T2 KISS, there was a fairly decent fundal cap. We ended up doing an ABR for this patient just to see what his ABR waveforms were, and they were completely absent on that side. So I wanted to query the panelists to see what they would do. Would they observe? This is a young patient. He's pretty disabled in terms of his dizziness. He has very good hearing. Would you radiate it? The hearing is really good. Does the radiation adjust the dizziness, or would you do surgery knowing that he has absent waveforms on ABR?
Yeah, so Dr. Link, do you want to?
Sure. It's very challenging, I think, decision-making. So I would overall strongly lean towards treatment over observation. Once the tumor gets above 2 centimeters in the cerebellopontine angle, I get a little bit nervous, particularly in a young person. It's not an urgent situation, obviously, but that's the first decision point. Should you treat or observe? I would vote for treating. And then I would talk to the patient about both options. It certainly could be treated with radiosurgery or remove it through a retrosigmoid approach. I would say in our hands, the chance that we could preserve useful hearing is less than 10% for a tumor this size. The one thing that was interesting to us is when we looked at our patients in the dizziness handicap inventory, it didn't matter whether we radiated them or observed them or operated them. The patients who showed up in our office and said, I'm very dizzy, I'm disabled by dizziness, did not get better no matter what we did. And the patients who didn't have much dizziness when they showed up stayed fine. We didn't convert anybody to having bad dizziness. So I don't think dizziness helps us decide what's the best treatment, at least from what we've learned.
Dr. Kanzioka?
Yeah, I agree with Michael. I wouldn't favor observation in this case, and I think this could either go radiosurgery or resection depending on the patient's own goals. If it's hearing preservation, I think it's kind of optimal given the fact that it doesn't fill the canal. You know, there was a prior NYU paper and a bit of a bias that if patients had a lot of dizziness, that they did better with resection. But our recent data on this agrees with what Dr. Link just said, that it doesn't seem to be a big difference. Nevertheless, that's kind of population-based data, and you just never know in one person versus another whether they might be helped, you know, by a resection or by something else. So it really depends. If it's not too bad, and the kind of person who might be okay with vestibular rehab and therapy and putting up with compensating over time, then I think it's okay to do radiosurgery.
Dr. Yang?
I actually had a question back for Dr. Dana, is that I think what we would try to do here is we would actually try to do low-dose gentamicin injection into the left ear to try to extract the dizziness and vestibular symptoms away from tumor control, so that you have two separate issues here. Tumor control, which I agree with Dr. Link and Dr. Kanzioka's intervention, but the dizziness is a separate thing. Have you tried, or do you have experience with doing low-dose gentamicin injections in the ear to make that, you know, it's ototoxic at high doses, but just enough to kill the vestibular nerve and improve balance, like you said, to make them rely on the other side?
I myself have done some gentamicin injections. I don't really prefer them. In fact, it actually makes people more dizzy before they get better, because you're actually losing vestibular function before you're actually compensating. And in patients that, you know, are older, who rely on any vestibular function input from different things such as eyes and ears and spine and legs and arms and whatnot, I generally tend not to do gentamicin injections, only because that little bit of function may be important for their ability to walk without a cane. So in this particular patient, I probably wouldn't recommend IAT gentamicin, only because about 30% of them do lose hearing, and it doesn't address the tumor. So generally, I wouldn't do gentamicin off of the bat. I do want to now go over kind of what we ended up doing for this patient. He was young. He was kind of anxious. He wanted the tumor out. The most important thing was his dizziness. Obviously, hearing is also important. So we ended up doing a retrosigmoid approach. We were able to achieve a gross total resection. It was an inferior vestibular nerve schwannoma. We had no ABR waveforms before and after the surgery. The facial nerve was intact. But what was unusual about this case was, which is not what I see very often in my surgeries, is that the superior vestibular nerve was really normal appearing. It was thick, it was healthy, and we ended up keeping that superior vestibular nerve, thinking that any little bit of function is going to actually help him, because he's a marathon runner, he's a triathlete, and so we ended up keeping that for him. And post-operatively, we were able to preserve all of his hearing, 100% word recognition score, maybe a 5% drop in the pure tone thresholds, but he had prolonged dizziness after the surgery. He actually required 6 months of vestibular therapy and yoga to actually get to some of the high energy activities that he was used to doing. He's doing great right now. He's back to running marathons, but definitely, you know, we came in trying to figure out how we can treat the tumor and treat the dizziness, and we ended up treating the tumor, treating the hearing, but he still had a a prolonged protracted course of dizziness. But in the end, overall, he is very happy now that he's back to his activities, which then goes to my next case, which is a very, very similar patient. He's 36 years old. He has a tumor in the opposite here. He has right progressive hearing loss. He has severe imbalance, but he was falling to the right. Every time he walked, he was just falling to the right, and this just kind of progressed over 9 months. And he's a project manager at an architect firm, and he was unable to work because of the imbalance. He had no significant past medical history except for hypertension, which was controlled, and his physical exam was unremarkable, except for his vestibular exam. Out of proportion to kind of what I generally see in my vestibular schwannoma patients. At rest, his eyes were beating to the left. When he looked to the left, it even beat it faster. And we did the head shake test, and I always expect it to beat to the opposite side, and that's what we saw. But then he had a periodic alternating nystagmus, which started beating to the opposite side, and then to the left, and then to the right, and he had some vertical aspects to his dizziness as well. And when I see things like that, I think that patients may not do very well after surgery, or just not doing very well in terms of balance, or not compensating very well because something is actually pulling it to the opposite side, or pulling it up and down instead of just kind of causing a global hypofunction that people can better compensate from. And when he did the Romberg and the Fukuda test, he couldn't barely do it. He basically almost fell to the side. And this was very unusual. We did a hearing test, almost the exact same hearing, a mild sensory neural hearing loss, 100% word recognition. And we did the MRI, and this is what he ended up having. He had a approximately 2 centimeter tumor centered at the internal auditory canal, a little bit of extension into the cerebellopontine angle, but absolutely no fundal cap on this patient. We ended up doing an ABR, and there were no waveforms. So in this 36-year-old who is very disabled, his main concern is his dizziness, and hearing loss is a secondary concern. What would the panelists do in this situation?
So that's a really interesting case, and this would be a patient that we would absolutely send for formal vestibular testing, because just as you pointed out, I'm concerned there's something wrong with the left ear. And we've had a handful of patients over the years that I can think of a couple of patients that actually had superior semicircular canal dehiscence and a vestibular schwannoma. Of course, a lot of patients get told they have Meniere's disease when they show up with dizziness and hearing loss, but we've had patients that had a Meniere's ear on the other side. So I would want to really know, is the left vestibular system working normally? And if it, assuming that it is, I wanted to ask you, based on your first case, you said you saved the superior vestibular nerve, and I've heard Professor Sami say he always preserves the vestibular nerves when he removes a vestibular schwannoma so the patients can compensate better from their balance. But I've heard a lot of otologists say the best thing to do is wipe out the vestibular system on that side, so then the other side will take over and they'll compensate. Our experience has been that sometimes patients cannot, meaning if you take one of their vestibular systems, which is functioning, let's say at 60%, and the other vestibular system is functioning at 100%, by comparison, and you wipe out the one hypofunctioning system, they actually do worse. There are some people, I think, who need some input from both sides. So I don't really know what the best answer is. I think it's tempting to say we're going to go in and clobber your vestibular system on that side and maybe you'll be better, but that's not necessarily been our experience.
I agree, Michael, and I think until we're doing serial BNGs or some type of quantitative assessment of vestibular function over time and looking at what recovery means for these people, our understanding of this is partial. I mean, this is not a common patient we see. Usually by the time you get to this size tumor with preserved hearing, many of these people have already compensated. I mean, there's no compression on the peduncle. So I'm not sure what the best thing is to do for this person. You might still follow the hearing preservation and say, many people are not willing to sacrifice hearing preservation to make their dizziness better, but maybe this person would and choose surgery for maybe the perception that they would compensate faster with a resection. I don't know. It's a difficult call.
Yeah, honestly, we would push this patient to try vestibular rehab. We would try and stall basically to see how they're going to level out. But I'll also say, quite honestly, some of those patients then just go up the road and have surgery. So I don't know if it's a strategy I'd recommend, but that's probably what we would do.
And that's the exact thing I was inferring with the injection as a chemical ablation of the vestibular system to go to the other side. And you're absolutely right. Is there something going on the other side? We've seen the same thing, a superior semicircular canal Hissens patients with an acoustic neuroma. And so the balance, and Dr. Kanzioka mentioned earlier, there are things we can measure. Balance is really hard to measure. And it's easy to get institutional bias because I think it differs from practitioner to institution. And Dr. Kanzioka can probably talk to that more. But even, from San Francisco and UCLA, I've seen that VNGs and BEMP studies, they can be institution dependent.
Dr. Kanzioka, for your radiosurgery patients with balance, do you do anything after radiosurgery? Like, is everybody that has any balance issues go directly into vestibular therapy, or do you have a set protocol for that?
Well, it's offered to them, and I would say that the motivated patients will do it, and many of them will report that it's provided them with value, and at least they're kind of taking care of their health issues. Obviously, if someone's very active, it may not matter that much to them. So we certainly recommend it. The value of it remains to be seen, but I think it's a good thing to do. Does it help people compensate faster? I think that still remains a question.
So for this particular patient, he didn't end up getting vestibular testing. We had talked about that option and whether that option would really change the management that he wanted, which was surgery. He was a young patient. He was very anxious. He didn't want the tumor in his head. So surgery was like pretty much the #1 option for him. And so we ended up not pursuing vestibular testing. We ended up proceeding to a retrosigmoid approach, thinking that removing the tumor would actually improve his balance and improve his dizziness. We ended up achieving a gross total resection of the inferior vestibular nerve. We had no ABR waveforms before and after. His facial nerve was intact at the end of the surgery, Housebrackman grade 1, but unusually his superior vestibular nerve looked amazingly normal, and we ended up keeping it, kind of similar to our other patient. Postoperatively, unfortunately, we weren't able to preserve his hearing. We were able to preserve very good thresholds, but 0% word recognition. And in fact, that residual poor hearing was actually interfering with his ability to hear from his good ear, and he was kind of miserable from that now. And he also had a very prolonged dizziness. His dizziness did not get better. He did 6 months of vestibular therapy and he didn't get better, and I pushed him really hard. Eventually we ended up getting a VNG and VEMP to see what was his superior vestibular nerve function, what was his inferior vestibular nerve function, and there was no function. So both nerves essentially were not functioning on these tests. It might be the limitation of the test, or they were just actually not functioning. And this patient, well, I just didn't know what to do. We kind of threw out a couple of thoughts and a couple of ideas, and we tried the intratympanic gentamicin, and we did it twice, no effect. And we talked about cochlear implantation and translabyrinthine approach for vestibular nerve section. And he's like, no, I just want my hearing gone. I don't want this noise in my ear. In fact, I'd rather be deaf than have a cochlear implant. And my main concern is the dizziness. So we ended up doing a translabyrinthine approach. We went in and I divided the superior vestibular nerve, but what I also did for him was I also divided the cochlear nerve as well, thinking that, well, if he had no vestibular function in his inferior inferior and superior vestibular nerve, did he have vestibular contributions in his cochlear nerve, which is a phenomenon that has been described over the years and is something that we can't test on vestibular testing. Immediately after the surgery, obviously he had no hearing, completely happy with no hearing in that ear, and the dizziness and imbalance completely resolved immediately after surgery, no nystagmus after surgery, and a very happy person. And so the reason why I wanted to present this case is just to highlight the importance of balance in quality of life in patients with vestibular schwannoma. And I think in certain situations and certain patients, perhaps it's impossible to be able to treat both the balance and the hearing loss, especially if there are some vestibular contributions that run within the cochlear nerve. And the only way to be able to remove that, those aberrant vestibular nerve fibers is to remove the cochlear nerve. Perhaps it's something in certain patients that we won't be able to do both. I just wanted to kind of show this figure that I got from the Journal of Craniofacial Surgery, and there's several of them in various different journals. But it basically, through a radiographic and anatomical study, there are anastomoses between the facial nerve and the superior vestibular nerve. There are anastomoses between the cochlear nerve and the inferior vestibular nerve, and perhaps it's the vestibular contributions to the cochlear nerve that is causing people to have persistent dizziness, and something that we don't really understand very well and can't treat very well. But at least for these two patients, I think dizziness was the most important thing to them, and in the end we were able to treat it, obviously through different ways. And so that's the end of my talk.
Thank you, Christine.
You're welcome.
Any comments? Okay, Dr. Morcos, we have a few minutes left here. Did you want to?
Oh yeah, if it's okay, I'll just show very quickly something we.
While you pull up your slides, a couple more questions. There's 2 or 3 questions from the audience that just ask about, the risk of radiation on facial nerve function that during a surgery after the tumor has progressed after radiation. What do you tell patients about the worsening adhesion of radiosurgery that people tend to talk about?
Well, from our perspective, it hasn't been very different from a fresh tumor at our hands at NYU. So I think for people who are skilled, we don't have to do it very often, fortunately. But I've been very pleased with the facial nerve outcomes in previously radiated tumors. It has a lot to do with the time of the surgery. If you're doing this, if you think you're doing it within a year, there's inflammation going on. If you're doing it later, most of that has settled down, but we've been very pleased with it.
I think it does make a difference. Fortunately, also, we don't have a very extensive experience. When we looked at our data, the one thing we found is we were doing more subtotal resections after radiosurgery when we did a comparison to size-matched unradiated tumors. But I think there's no getting around. Sometimes this operation is really, really difficult and the planes seem bad, and sometimes it's not so difficult. So it's hard to know how much radiosurgery or any radiation contributes to that.
Mike, it's okay. I'm having issues sharing. I don't know why. I'm not going to waste time, but maybe I can say it verbally. Sure. So it's a CP angle tumor, patient 58, and having decreased hearing. Audiogram is normal, 100% bilaterally, slightly dizzy. So I go in retrosigmoid, and essentially everywhere I stimulate with the NIM stimulates facial nerve. And question, I'm sorry, I had operative pictures to show, but I can't. Mike, what would you do with a situation like this? There is no window into the tumor without facial nerve stimulation directly with the NIM.
And how big is the tumor?
It's 2.4 centimeters. He's 58 with normal hearing.
So we've certainly encountered that. And You know, if there's a window to get into it, that's great. You can do a subtotal resection. But if there's not a window, then we just stop, and then we treat the patient with radiosurgery. I just did a video visit with a patient that has had video visits, I think, with you, Doug, and with Dade, and with Marcos Tadijiba in Tübingen, and the group at UCSD, and so on and so forth. So this is not an uncommon scenario, but I think the thing to do is assume it's a facial schwannoma and not plow through the facial.
Yeah.
Doug, you agree?
Yeah, I think we've had a few recent cases, including a young surgery resident who decided, you know, I'm going to have surgery, and then the exposure by a very skilled person described exactly what you just said, Jacques. They just closed, and then we ended up doing radiosurgery for it. And this doesn't happen, you know, we see this once a year, and I think we're seeing seem to be seeing more facial schwannomas than we did in the past for some reason. I'm not sure. It's just maybe the diagnosis being more. I saw one today, as a matter of fact. We're seeing more of it.
Well, the other thing I'll add, Jacques, is often we will open the IAC to decompress that component of the tumor, not with the goal of taking any tumor out, but just thinking about potential post-radiation swelling and not wanting to get the rare post-radiosurgery facial weakness.
Yeah. So, Isaac, any other opinion?
I think what you're highlighting, Dr. Morcos, is a really key point. Is if this patient had gone straight to radiation without any surgery, it would have been assumed it was an acoustic or CP angle tumor that just got radiated. We would never have known it was a facial schwannoma. And so I agree with Dr. Link and Dr. Kanzioka that this is going to be another subset of tumors that are assumed to be acoustics, but actually, as you found out, was a facial schwannoma.
Yeah, so I did manage, oh, go ahead, sorry.
I wanted to mention that it may not be a facial nerve schwannoma. Like I said before, they are anastomoses between the superior vestibular nerve and the facial nerve, and it could in fact be a superior vestibular nerve schwannoma that has anastomoses with the facial nerve, and trying to find the facial nerve within the IAC, or at least somewhere where it's normal, where you can separate the superior vestibular nerve from the facial nerve, might be a way to be able to resect it safely. I just mentioned that because we're all talking about facial schwannoma, and which is a very rare entity. But just going back to my talk, there are anastomoses between those nerves that can contribute and cause that phenomenon to happen.
Yeah, in this case, again, sorry, I can't show the intraop pictures. It is really a facial nerve schwannoma. You could see the vestibulocochlear pushed infero-superiorly. So I did manage to do a partial resection. This is 9 years ago. And I did give Gamma Knife, and I was going to show you that actually the dramatic response to Gamma Knife, I would say 80% of the residual, I had left a significant residual, 80% of it is gone 9 years later. And I was going to have kind of two questions, maybe to Doug. Doug, do you think the response of facial nerve schwannomas to radiosurgery is any different for the same volume than a vestibular schwannoma of the same size? And number two, effect of partial tumor surgical resection on biologic susceptibility to radiosurgery?
Well, I've certainly seen some impressive regressions in occasional facial schwannomas, but I think that I've seen it more in trigeminal schwannomas. That's a tumor for some reason really has a unique response pattern, but I'm not willing to claim that the facial schwannoma is yet anything special. Right. But there's clearly, you know, after your second point, you know, is the tumor devascularized after surgery? Is it biologically altered? I think it has to be in some way, or not even just from a devascularization, but just being there. You know, the body's immune system can certainly affect the tumor, and certain people lay down more scar tissue after a microsurgical resection than others, even if it's clean. And you all know, you know, that when you see the linear enhancement and more, you know, it could be more or less. So there's no doubt that probably to some degree there's an effect of this.
Okay, thanks, guys.
Isaac, do you think that this is maybe the one situation where DTI tritography will help? Have you done that on any facial schwannomas?
So again, facial schwannomas are really rare, and so you're not going to see a whole bunch of them, but you're right. This is the whole point, is that right now they make beautiful pictures and they don't make a lot of clinical impact, but we have to keep pushing this boundary, because as the imaging gets better, we're going to be able to see that better. And so you're right, this could be one area that in the future could help delineate that. And I think Dr. Morcos is just doing adaptive hybrid surgery for facial schwannomas. He just beat us all to the punch.
Yes, but only for them, not for vestibular schwannomas. The concept makes absolutely no sense, but that's okay.
Okay, great. Well, it's already past 6:30. I just want to say thank you to all the panelists and Dr. especially for joining us tonight. So we have another 15, 20 questions, but I'm going to cut it short. I wish you guys all well and stay safe.
Thank you, guys.
Thanks. Thanks, everyone. Great to see you all.
Thank you.